Okay, welcome back to today's webinar. My name is Dr. David Kunashko. I'm a chiropractor and acupuncturist, been practicing for a long time, I guess around 30 years now. So I've been involved with low-level laser therapy or photobiomodulation for well over a decade now. I'm the Director of Education and Training here at Meditech. We, of course, manufacture BioFlex laser therapy. The title of today's webinar is really meant to educate clinicians or even just general public, but more clinicians, what laser therapy is, sort of what it brings to the table therapeutically, and specifically, what are the things that you should be looking for when you're purchasing a system. Now, you might say I'm biased. I have tried a lot of different lasers over my career, from class 4 to different class 3B lasers and so forth. And I will offer my opinions for sure. Of course, I work for BioFlex, but there's a reason for that. I was a patient for a long time. It really helped me more so than class 4 and some other devices. And the more I saw and observed, especially Dr. Fred Kahn, who's the CEO and founder of Meditech, I was really convinced that this equipment was by far the most advanced and most effective. So that's my take on it, but certainly I will offer lots of different things that you should think about when you're looking at laser therapy. So I'm going to talk a bit about what photobiomodulation or laser therapy is, just some of the basics of it. If you've listened to my webinars before, then you already probably know this information, but for a lot of you folks out there, perhaps you haven't. You can ask questions anytime. However, I won't get to the questions until the end of the webinar, just to let you know. The webinar is recorded, and we, of course, send out an email with a link to watch it again if you choose to do so. I'll talk a bit about some of the research. There's lots of it, about the clinical applications for your practice, and then really get into what laser therapy devices, what you should be looking for when you're getting a laser therapy device, and of course Q&A at the end. So really phototherapy, or the use of artificial light for treatment of medical conditions, really started with Dr. Niels Finsen. He won the Nobel Prize in Medicine or Physiology back in the turn of the 20th century. And he used red light, infrared light, he used ultraviolet light to treat measles and skin tuberculosis, a lot of different conditions. He was way ahead of the game. You can see one of his devices here. He got tremendous results, hence why he got the Nobel Prize. Now, he actually died prematurely just as he was awarded his Nobel Prize from complications of a hereditary disease called Pick's disease. But he is the one that first really observed what happens to the physiology and metabolism in his early research on amphibians and small animals, and then he brought that to the table on humans. So he really is a person that introduced phototherapy to medicine. Now, lasers were developed in the 1960s, and the first lasers in medicine really were high-level laser therapy, or HLLT, and they used for surgical applications. Of course, they burned and vaporized and carbonized the tissue. So they were used as a tool to remove tumors and cut things out and lob things off, that kind of thing. But what was really interesting was they noticed that when they were using lasers as a surgical tool, the healing was much faster than a scalpel, and there was less complications and less scar tissue with lasers. And they weren't really sure what was going on there. But if you look at this diagram here, you can see that it's like a bullseye where you are hitting now the first lasers were red, by the way, which is really critical because it's red wavelengths that actually create photobiomodulation. So these red lasers, high power, would burn and cauterize, but as the light penetrated deep into the body, it eventually got to a zone where it was athermal, so no heat production, right? And that's called, what we refer to now as low-level laser therapy or LLOT. So a photoactivation zone. They didn't notice at the time, but this zone around the destructive area actually accelerated the metabolism and healing of the damaged tissue. So that is why, in fact, they saw much better results with lasers compared to scalpels. Now, it wasn't until Dr. Andre Mester in Hungary, who around the same time as lasers were being developed, started to do some preliminary work with high-powered lasers, or what he thought were high-powered lasers, on cancer and tumors. But what happened was his laser was calibrated much lower than he anticipated. He didn't know this. And when he was trying to treat these tumors, what he noticed was some hair growth compared to control. And he wasn't sure why the metabolism of the hair follicles increased with this red light. So he did subsequent experiments on skin flap wounds, which is shown here. And you can see on the left is a control, on the right is the rat with just that one lesion treated with red laser. So if you compare it to control, you can see it's actually healing quite a lot faster, right? And then the adjacent wound, which was not treated with laser, is also healing faster than the control. So Andre Messer is considered the father of low-level laser therapy. And this observation is critical because, number one, he recognized that intense red light, but not so intense that it causes heat, it can produce rapid or accelerate wound healing. But really, and most importantly, or not most importantly, but also that's important, is that adjacent areas respond as well. So he deemed that there's a direct effect and an indirect or systemic effect modulated via the blood. So when you're using photobiomodulation, there's two targets. There's a direct tissue that's injured or diseased, and then there's the indirect blood that you're trying to immunomodulate, mainly the white blood cells and stem cells, that of course circulate around the area and can help with inflammation, because white blood cells control inflammation. They also help control healing. So you're getting twofold effects if you treat the blood and if you treat directly. And that's something that you need to look at in a laser therapy device. Is it a quick treatment? No, if it's a quick treatment, there's no systemic effect. It's just not on the blood long enough. If it's on for longer periods of time, then you can get a systemic effect as well as a direct effect. Now, laser therapy terminology is all over the map. There's like well over 70 terms for laser therapy, cold laser therapy, LED, phototherapy, on and on and on and on. So that led to a lot of confusion. They kind of settled on low-level laser therapy. Then they realized that high-powered LEDs or superluminous diodes also have a healing effect. So then it was called low-level light therapy. And eventually they decided to choose the term photobiomodulation therapy, or PBMT. And this was added to the MESH database, which is a database for tracking articles, research articles on PubMed, Medline, and so forth, in 2016. Now, by definition, photobiomodulation, again, or cold laser therapy or light therapy, is a form of light therapy that uses non-ionizing forms of light, so we know it's very safe. You can use a laser diode, you can use LEDs or superluminous diodes, or broadband light. It depends on what you're trying to do. So I'm going to explain that as we go along. This process is athermal. You should not be producing heat. So when I get the discussion about, well, what about class 4 laser therapy? Well, it's a laser, it's therapy, but it's not photobiomodulation. So all the research I'm going to quote, and in fact, the thousands of papers out there on photobiomodulation use this definition. That is, the diodes aren't creating heat. So wavelengths are different, the power is different, lots of things are different. So this isn't a discussion about class 4 laser therapy, because that's like comparing, a tomato to a cherry, right? They're both fruits, I guess, but very different. Okay, so this whole process leads to stimulation of photoreceptors. They're called chromophores, and it can cause a photochemical or photophysical reaction. Think photochemical like photosynthesis, right? That's kind of what we're dealing with here. And the net result is it creates beneficial outcomes, including reduction of pain, so analgesia, reduction of inflammation, immunomodulation, so increased stem cells, promotion of wound healing and tissue regeneration. The mechanism is pretty straightforward. Well, I say straightforward in that it's been pretty well established, although there's still lots of things to learn. So the main target for the mechanism of action is in fact mitochondria. And if you recall the electron transport chain, which of course is critical for the production of ATP, this is aerobic respiration, so oxygen combined with glucose creating ATP is the energy currency, of course, for cells. So cells need to convert ADP into ATP to drive metabolism, regeneration, repair, all these good things that we, of course, need when we're trying to heal an injury or deal with inflammation in the body or what have you. Unfortunately, when you have a state of inflammation, so for example, arthritis or sprained ankle or tendonitis or tendinopathy or whatever condition you're treating, there's usually inflammation. And inflammation causes an increase in a molecule called nitric oxide. This is within the cell. Now, nitric oxide in low concentrations is actually very beneficial to cell function. But as the concentrations get higher due to inflammation, it actually inhibits metabolism. It does that by actually binding to cytochrome C oxidase, one of the terminal enzymes in this electron transport chain. By doing that, it actually inhibits the production of ATP. The proton gradient pump declines, the amount of ATP decreases, and then this sets up a cell cycle that basically tells the cell, well, I don't have energy, so I need to stop doing what I'm doing, including regeneration, undergoing mitosis, repair, all these kinds of things. And if it's prolonged, the cell can undergo something called apoptosis or cellular death, which is not good, right? So the whole goal of therapy is to reduce inflammation. Inflammation is everywhere. That's the bane of our existence. We get old because of inflammation. We have injuries, we have inflammation. We have GI problems, inflammation, Alzheimer's, inflammation. It's all due to inflammation. So if you can reduce inflammation, right, then that's going to be helpful. So there's many ways of doing that through diet, nutrition, exercise, all these different things which you should be doing. And there's other therapies that can help as well, but this works very differently. So how laser therapy works, or photobiomodulation, is certain wavelengths, especially red and near infrared, can interact with a nitric oxide that's bound to that cytochrome C oxidase when it's highly concentrated due to inflammation. Now, nitric oxide has a very short half-life. It actually disassociates fairly quickly, and it's also free to diffuse through the cellular membrane into the blood. One of the secondary effects of photobiomodulation is temporary vasodilation, because nitric oxide, as it is released due to the interaction of the light on cytochrome C oxidase, can in fact freely diffuse into blood, causing temporary vasodilation. So the light actually interacts and breaks the hydrogen bond between nitric oxide and this enzyme. By doing that, it actually allows the now increased production of ATP. It normalizes the metabolism, and now you start to get ATP production. So with ATP production, you get lots of other trickle-down effects. I'm not going to go into in-depth about this particular slide, but essentially what happens is you increase ATP, you cause a spike in a free radical called ROS. This short spike causes a reaction with an enzyme called nuclear factor kappa beta that triggers the cell to produce what are called stress proteins. And the stress proteins help the cell recover from inflammation. So it's a positive thing. When you increase ATP, you increase the activity of the sodium-potassium pump, right? I mentioned about nitric oxide. Its release into the blood causes vasodilation, which of course is good for clearing out waste products, metabolites, and then bringing in fresh blood and oxygen and so forth. And light also has the ability with these wavelengths to increase the efficiency of the calcium ion channels in cells, which of course we know is critical for things like nerve conduction and muscle contraction, that kind of thing. So it's quite complex. I go into more depth when I do a training session, which I'm doing a week from tomorrow, if you're interested. So the effective wavelengths, remember I said lasers, the first ones were red? It was just by chance because they were using a ruby crystal to make the laser. Well, it turns out that when you look at the photo absorption spectrum of cytochrome C oxidase, and you look at the absorption spectrum of blood or hemoglobin and water, then there's this sort of window of opportunity that you can stimulate this enzyme with light. And that just so happens that around 630 to 660 nanometers stimulates this enzyme, so that's red, right? And they also discovered near infrared around 780 to around 840, 850. You can creep up to 900, but the best wavelengths are between 780 and 840, 850. And I say that because that's what the research says. So I know people will say, what about superpulse? It's 905, blah, blah, blah. Yeah, it's okay. And it does work, but the research actually shows that 810, 820, 830, around there is the most stimulatory. If you want to see the research, I'd love to share that with you another time. So the wavelengths that you're looking for in a device are red and near infrared, not blue, not yellow, not green, not ultraviolet. These are the wavelengths that are traditionally used in the research for photobiomodulation. Okay, I don't want to hear discussions about blue light or green light or yellow light. They have definite physiological properties that can be beneficial, but they're not used the way red and near infrared are because they're so poorly absorbed. Okay, now the next thing you need to understand is a dose response curve. Dose response curve with respect to laser therapy essentially is that there's a dosage range where this blue arrow is showing you that as you get into this sort of peak range, you're going to have really good results. But if you start to go over that dosage, that is, the energy is too high, you start to get diminishing results. You'll still get results, but not as good as the lower levels. And then if you start to really increase the power, you actually get an inhibition, which sounds bad. But if you want to block pain, then you're after inhibition. So if you really ramp up the energy density, you'll get analgesia, which is good, but unfortunately, it's beyond the band for healing of photobiomodulation. So you can't do both. You're either going to zap the nerves and the nociceptors or pain receptors and block pain, which is, you know, good, but you're not going to create healing. So you can do it in several ways. You can treat the patient for pain initially, get them out of the pain, excuse me, and then do photobiomodulation. Our approach is more photobiomodulation, try to reduce the inflammation. You'll get pain relief that way as well too. Okay, so that's the dose response curve. Again, I'm going through this pretty quickly because it's not a training session. Oh, I should have mentioned, by the way, if you continue to increase the power, you'll eventually get tissue damage because of heat. So that's a class 4 laser, right? So you have to be really careful if you're using class 4, that's heating, and of course that will inhibit photobiomodulation. So I'm not talking about dosages so high you get heat production, okay? Now, the other thing you need to be looking for when you're looking at laser devices is, are there parameters that you can alter or customize or change? One of the parameters is pulsing the light. Now, pulsing the light is known to actually increase the efficacy. There's not a huge amount of research, granted, but there's enough research to show that pulsing light seems to be more beneficial in a lot of different conditions than a continuous wave. Okay, again, if you want to see the research or whatever, I'd love to share that with you, but I don't have the time today. So what pulsing is when you flash the light. So when you flash the light, as the light's on the target, then you will stimulate ATP production, right? Now, if you stimulate ATP production too much, there's a negative feedback loop that basically says the cell is saying, I'm full, I have enough ATP, let's slow things down. So what you want to do is turn the light off, creating a dark phase. In the dark phase, what happens is that the cell digests or uses the ATP. Okay, so during the dark phase, ATP levels go down. And then as they go down, well, you want to stimulate them again. So you turn the light back on. Okay, now basically that's pulsing. You turn the light on, stimulate ATP, you turn it off, no ATP production, and then back on. So you flash the light. Now, different cells require or are stimulated by different frequencies. And it really has to do with the mitochondria, because some cells have lots of mitochondria, like nerve cells, muscle cells. Other cells, like bone cells, fibroblasts, other types of cells have much fewer or have fewer mitochondria per cell type. So they're still trying to figure this out, but what Dr. Khan has done over 3 decades of working with patients is he's tried to establish these pulses or frequencies based on tissue type, based on the condition, the inflammation that's going on, to make it easier for the practitioner to choose a protocol that has built-in frequencies. Otherwise, you have to literally start from ground zero and figure it out yourself, which you can do, but as a clinician, time is important, and you may not want to always be spending a lot of time experimenting for every patient. So the analogy I give is essentially, if you're trying to stoke a fire, like with coal, for example, you don't want to put too much coal on it because then it will diminish the fire. So you just put enough to get it going, let it burn out a bit, then put more back on, kind of like stimulating with light. Lots of research on photobiomodulation. Last time I checked, there was over 7,000 papers on PubMed when you search LLT or PBMT. And if you look at clinical trials, so you just click on clinical trial or randomized trial, there's well over 1,300 published randomized control trials. So there's a huge amount of research published every year. Anywhere from 400 to 500 research papers are published per year on photobiomodulation. Lots of research journals as well. I won't go into their names, but they actually target, or not target, but they discuss using lasers in medicine. And they usually combine both high-powered and low-powered, but you'll see articles on both. Different associations like the World Association, North American Association, European, they have conferences. Well, they used to have conferences, but you know what? COVID is rapidly declining, which is really good. So we'll get there. We may not get to herd immunity, but we don't really even need herd immunity, to be honest, in this summertime and fall time. I heard lately that actually it will be considered kind of like a common cold, where people will have enough protection such that they may get COVID, but it will be kind of like a common cold because you'll have antibodies and so forth from previous infections or from vaccination. So that will take a few years to get to that point. Anyway, lots of research like published in The Lancet. This one was a meta-analysis published by Roberta Chow. She's actually spoken at some of our conferences in the past, and her paper on neck pain was really well accepted in this high impact factor journal. Cochrane reviews have been positive. This one was a Cochrane review for frozen shoulder adhesive capsulitis, basically saying that exercise therapy and photobiomodulation or low-level laser therapy gave moderate effectiveness, which is actually quite high, and no other modalities were actually effective. So that was quite good. British Medical Journal put out evidence-based guideline on treating knee osteoarthritis with photobiomodulation. They looked at 22 randomized control trials. Again, really high degree of efficacy. The American College of Physicians and Surgeons put out a position paper evidence-based guideline for treating low back pain. And in it, they mentioned things like Pilates, yoga, manipulation, exercise therapy, active things. They don't recommend injections or medication, which is quite amazing considering it came from the physicians. And they, by the way, mentioned low-level laser therapy. So that was pretty cool. And no other modality, by the way, did they mention. Clinical applications are really varied because it works on all cell types. It can improve circulation. It can help with collagen production. It can help with repair with muscle tissue, reduction of inflammation, pinched nerves, compressed nerves, neuropathy, torn meniscus or labrum, fractures. These are all potential tissues that can respond to photobiomodulation. You know, I'm not going to go through each and every one of these conditions, but you can imagine everything from the neck, like arthritis, degenerative disc disease, whiplash, rheumatoid arthritis, you know, muscular strains in the lower back, stenosis, sciatica, DDD, all these types of conditions that a chiropractor or other clinicians, physiotherapists, massage therapists, TCM practitioners, you guys treat all this stuff day in, day out. And you're maybe listening in just because you may have heard about laser therapy and are a little bit curious. I can say over the last 10 years that I've been doing this, it's been increasing exponentially with respect to the interest and the number of practitioners utilizing it. You know, tennis elbow, torn meniscus, I've mentioned that, carpal tunnel syndrome, rotator cuff tendinopathies, plantar fasciitis, those kinds of things. So all the musculoskeletal conditions, lots of good evidence that it can be effective. Lots of dermatological conditions, everything from aging and cosmetic conditions to wounds to acne, psoriasis, vitiligo, oral lichen planus, lots of things that there's good research to show that can be effective because why? Well, there's inflammation, okay? And this can be very helpful for that. We use it a lot for wound care. In our clinic, we have a dedicated wound facility that people come in with recalcitrant wounds that aren't healing due to diabetic issues or circulatory issues or what have you. But even just post-surgical healing, hematomas or whatever, very beneficial for healing. And of course, neurological conditions from pinched nerves. I mentioned things like neuropathy, compressed nerves, herniated discs, and of course, there's post-concussion syndrome. There's being research done on that. Even neurodegenerative conditions, there's being research in Alzheimer's, dementia, a lot of really interesting and promising results there. So it's fascinating how this is really growing in the medical field. So when you're looking at a laser therapy device, there's lots of things you need to look at, the clinical and technical specs. Are you able to market it appropriately? Do you get good training? This is not a ultrasound machine, right? This is not you open up the box, give 5 minutes of instructions and off to the races. It is not like that. It's somewhat complicated. You need training. You need to understand what you're doing, and you need ongoing training and education to get the best out of your system. If your company that's selling you something doesn't do that, I wouldn't consider it because you're not going to get the results you hope for. Is the product or the device easy to use? Especially, is it hands-free or mostly hands-free? Does it have the optimal parameters that I've discussed? Is it a safe device to use on your patients? All these different things you need to look at. So for example, wavelengths I've already discussed, red 630 to 680 are the ranges, near infrared 780 to 840, 850, and there are better wavelengths in there. I would stay away from class 4 if you're trying to do photobiomodulation. Class 4 is great for heating up tissue and causing an analgesic effect, but they're super expensive. And to be honest, it doesn't make sense. I can achieve analgesia with class 3B and I can get healing done. And if I want to create deep heat, then I use a thermophore, or I use a high infrared heat lamp. I mean, a lot cheaper, right? Now, the other thing you should be looking at is the device making contact with the skin. Some devices do not. They're held a distance away. I've seen them all the time. They're all over the internet. The problem is 85% of light reflects off skin. So unless you're treating just skin, it doesn't make sense because you're losing a huge amount of that energy to reflection. So the device should touch the skin, preferably the diodes should touch the skin. If the diodes are behind the glass plate, then it's like you're not really being able to push the diode into the skin. So the diodes should protrude so that you can push into the skin. And why is that important? Well, once you push into the skin, you depress the tissue, allowing the actual diodes to get closer to your target. And that's critical because light only penetrates a few millimeters to a centimeter to a few centimeters, depending on the wavelength. So if your target is deep, you want to get the light to the target, and you can't achieve that if you have a glass plate that you can't squish into the tissue, right? Literally, you can't do it. So you're looking at devices that should have protruding diodes. That's really important. Of course, you should be dealing with a medical device. Bioflex and Meditech, of course, has Health Canada, FDA clearance, CE in Europe, UL Underwriter Laboratory designation. We're an ISO medical class company. This costs a lot of money, to be audited by Health Canada, by FDA. That's why these devices aren't cheap. It has to do with all the things that you would not even imagine cost a lot of money. I'm involved with all this, so I know. You can't sell these things for cheaper because you just can't. I mean, not with the amount of money involved for the engineering and the regulatory oversight. Now, so when you're looking at devices, I mentioned earlier that the surface area is critical. If you're treating blood, you want to have a device that has a large surface area. So devices on the left here, you can see the surface area. It's behind a glass plate, these diodes. And while they're okay, the unfortunate thing is behind a glass plate, it doesn't allow you to depress it very well. So when you have, and also it's not flexible. So when you have a flexible array of lights, then you can bend it, contour it to the tissue, which allows the diodes to make contact 100%, as opposed to a glass plate that can't get around bony bumps or protuberances. Surface area, for example, our equipment is 75 to 100 square centimeters, the highest surface area you can get in the marketplace as far as the energy density goes, which means that you can treat a huge volume of blood. Why is that important? For the systemic anti-inflammatory effects. And the laser diodes that we sell are as a single tip probe, and now allowing you for that diode to actually get deep into the tissue as well. Safety-wise, again, I would look for a laser diode that doesn't have an on and off button. The problem there is that if you turn it on, now you have lasers coming out, and lasers can be potentially dangerous to the eye. So if you're not careful and it's on, you could actually cause damage to the eye. The contact sensor is where it turns off as soon as you take it away from skin, meaning that it's next to impossible to irradiate someone's eye, because as soon as you take it off the skin, it turns off. And we have a patent pending on this contact sensor with our equipment to ensure safety. The other thing is you should be looking at software. Is the software customizable? Can you change frequency, right? Pulses of light. Can you change the dosage, the parameters? Those kinds of things. If it's static, meaning that you can't change these parameters, then you can lose effectiveness, because that means you can't change up these different dosaging parameters to try different things on your patient, because every patient does react differently to light. And are there protocols embedded? Some people say the protocols are kind of gimmicky. Well, I disagree. Protocols are a recipe, and they're designed as a starting point. The protocols that we have in our system are designed by Dr. Khan, treating literally tens of thousands of patients over decades of his clinical career. These protocols are proprietary based on his results in a real clinic, right? We're not a manufacturer where we just say, yeah, we'll do a range of dosaging and say it treats the neck, and there you go. What's that based on, right? I don't know. So it's more experimentation if you don't have proven clinical protocols. And does the company have a clinical background? We are basically the only medical device company out there that sells photobiomodulation that also runs a large clinic. We actually run and operate North America's largest laser therapy clinic. So all of our devices are used on patients every day. We beta test all the new equipment, and that ensures the effectiveness, the safety, and really these protocols that we adapt and put into the software. So having a clinical background allows clinicians that work at the company to help you as a consumer and a clinician be more effective with your equipment, right? You can call us, you can email us and say, hey, Dave, I'm treating gout. I've never treated a gout patient. How would I approach that? And I would say, yeah, well, I've treated gout a lot. This is how I would do it. And you can say, okay, well, the patient's not responding. Should I change this or change that? We do it every day, day in, day out, not just me, but all of our clinicians. So they're available for you to be helpful and to make better use of your equipment as well. Does the company offer training and educational events? And really that's critical, because without ongoing training, then an ongoing understanding of what you're doing, you're missing out on advances in this really interesting type of therapy, and also not being as effective as you could by knowing all the nuances. Okay, that's it for my webinar. I do want to mention that we do have some upcoming BioFlex events, including a masterclass. Go to our website for more information. The keynote speakers are Dr. Ashley Bonjan, a neurologist out of Durban, South Africa, and he'll be talking about neurological applications. In his clinic, he has quite a large outpatient clinic at a hospital where he uses BioFlex on everything from sciatica, nerve-related issues, Alzheimer's, dementia, post-concussion, post-stroke recovery, and he's been treating post-COVID patients as well too, so that's interesting. Along with Dr. Jan Tuner, who's considered the preeminent expert in laser therapy for dental applications, but especially temporomandibular joint and tinnitus. So I'm really happy to have him speak. He's published, I don't know, 20, 30 papers on PubMed on laser therapy and dental applications. So I'm really pleased to have him, along with a whole host of other guest speakers as well. I do a training every month. Next one is a week from tomorrow on April the 16th. Again, you can go to our website and join us for that as well. And we have advanced trainings coming up, cervical spine region in September and cosmetic aging conditions in December as well. I really appreciate you taking the time today, because I know everyone is busy, although maybe with COVID you had a bit of a break at lunchtime. So if you have any questions, please ask them.